One, we are live now. We can start with the sessions.
Good evening, everyone. Welcome to you all by Ajanta Dermatology. Ajanta is Indian multinational pharmaceutical company with serving global healthcare needs since 1973 through empathy, innovation, and technology. We are a multinational pharmaceutical company in a 30 plus present in a 30 plus countries with 500 plus product and more than 7,000 Ajantites working with the 30 plus nationalities. We have advanced R&D center where more than 800 scientists works in a 1 lakh square meter area where we have complete value chain, formulation development, analytical development, regulatory affairs, synthetic development. We have manufacturing plants which are 7 state-of-the-art manufacturing facilities, out of which 2 are US FDA approved, one at the Python and one at the Dahej. Our CSR activities includes more than 54,000 free cataract surgeries, more than 3,000 family planning surgeries, more than 69,000 malnutrition treatments, and more than 8,000 skin plastic surgeries and others. Ajanta Dermatology striving to be your scientific partner. As a PG initiative, we have collaboration with Karnataka IIDVL and started the initiative Resimed K and Derm, which is ongoing PG skill upgradation program since June 2020 and has completed more than 5 years. During these 5 years, we have completed more than 170 sessions. We have collaboration with IIDVL like Y Academy, which is a young academy, a new initiative under the IIDVL Academy, which successfully completed 8 webinars. We also have SIG dermatosurgery workshop, which is PGPDT, that is postgraduate procedural dermatology training. In 2 consecutive years, across the 4 zones, we have performed 12 to 15 live surgeries, which are attended by more than 1,000 plus doctors. Also, along with the IIDVL and Gallon, every year we celebrate October 1st as the World Urticaria Day, where international speaker program arranged on urticaria. Our initiative, we have conducted almost 10 international speaker programs. Last 2 were with the Immunol Coste, Mexico, for the future of sunscreen peptide-based innovation in photoprotection, and latest global update in urticaria by Dr. Ivan. Our Skill Hands initiative, it's an academic initiative to enhance skills and knowledge, where more than 60 centers established across the India, where 100 workshops conducted and more than 1,000 dermats trained on a one-day hands-on or observership program conducted at leading aesthetic, cosmetology, and trichology centers. Our collaboration with ASCI to conduct 6 dermatosurgery workshop this year. 2 programs has been already conducted in April 2026, that is at AIIMS Bhopal and Command Hospital, Chandigarh. Our collaboration with Society of Eczema Studies, where we have successfully conducted 9 SES meeting for TMTA, that is Think Moisturizer, Think Ajanta Dermatology Summit, where more than 900 plus dermatologists attended. We are also honored with a title by the Asia Book of Records for the last scale Indian survey during the April-May 2025, where more than 5,700 responses from the dermatologists collected, which is a large scale rating survey for effectiveness from dermatologists and focus on 6 plus skin diseases, where 82 prescriptions for eczema, psoriasis, and so on. We are official record holder of India Book of Records for conducting real-time evidence of 25,000 Indian patients, which confirm that their perceived skin age is average 2.3 years more than the biological age. In this, more than 1,800 dermatologists across the India supported us, and we also successfully reached and educated more than 25,000 patients on sun protection. Ajanta Dermatology is striving to be your scientific partner. Today, in collaboration of Vitiligo Foundation of India, that is VFI, we invite you for an online webinar where 2 topics will be discussed: home-based phototherapy and office-based phototherapy. Let me introduce you today's moderator, Dr. Munish Paul and Dr. Dipti here. Dr. Munish Paul is a head of department in Manipal Hospital, Delhi, Director Skin Laser Center, Delhi, Founder President, Vitiligo Foundation of India. He is a MD Dermatology from the KMC Manipal in 1998, proficient in surgical, non-surgical lasers, dermatosurgery. Focus of work has been in vitiligo more than 25 years. His areas of interest are vitiligo, rejuvenation, and clinical dermatology. Our second moderator is Dr. Dipti Ghia. She is MD DNB FC Fellowship in Phototherapy, consultant dermatologist in South Mumbai Dermatology Clinic, Jaslok Hospital, Research Center, Mumbai. Also co-founder of VFI, that is Vitiligo Foundation of India, and co-founder of Jaj Dermatology. She have 12 articles, 5 book chapters, and presentations. Many presentations she have. She is a conveyor of IIDVL Vitiligo Task Force from 2024-2025. Joint Secretary IIDVL Maharashtra. Dr. Adarsh Kumar Annual Meeting Supplemental Scholarship, Strauss and Kaz World Congress Fund Scholarship she has received. She also attended American Academy of Dermatology, Washington DC 2016 sessions over there. Over to you, ma'am. Over to you, sir.
Hi, good evening, everybody. Good evening, colleagues. Um, from the team Vitiligo Foundation of India, I'm welcoming you to this webinar on phototherapy. So it's going to be a very interesting topic. So we have two eminent speakers with us, Dr. Madhulika and Dr. Devedi, and we're going to be touching on the practical aspects of using phototherapy, which we know can be in at home or in the office. So we are all aware we are in the third year of Vitiligo Foundation of India, and I thank all of you to be a part of us and joining us for this meet today. Over to Dr. Deepti to introduce Dr. Madhulika.
So, thank you, Dr. Munish. It's my pleasure to invite Dr. Madhulika Matre to take this talk on phototherapy. Dr. Madhulika is a gold medalist MD dermatologist. You all know about her, but she's the secretary for the Vitiligo Foundation of India, with the director and chief dermatologist at Skin Saga Center of Dermatology, Mumbai. She has many chapters, articles in national and international journals. She's delivered talks at different various national and international level. She has also received the Young Dermatologist Award at Mid-Dermacon. She's been convener of the IDVL Practice Management Cell. She's also the editor and the social media editor for the Indian Journal of Dermatology. And special interest group interest areas is vitiligo and trichology. And she's got many awards too. So welcome, Dr. Madhulika.
Thank you, Dr. Dipti. I am just going to start sharing my slides. So give me a second. Okay, are my slides visible?
Yes.
Perfect. So we all know as dermatologists, more so as vitiligo surgeons or people who see a lot of vitiligo cases, how important phototherapy is. So through my talk today, I'm going to talk about clinic-based phototherapy, how we can optimize it so that we learn to derive the best possible outcomes from it. So let's learn about the current concepts, practical pearls, and recent advances as far as clinic-based phototherapy is concerned. Now, I don't want to bore you with a lot of history about phototherapy, but I would love to mention this particular gentleman, Niels Finsen, who received the Nobel Prize for his work with UV radiation in lupus vulgaris, and he's the only dermatologist to be ever awarded one. So this is a tiny little bit of history which each and every one of us should be aware of. So now in the era of JAK inhibitors and so much fantastic research happening in the field of vitiligo, why does phototherapy still matter? It is still the gold standard treatment for generalized vitiligo. It's the first line for extensive progressive disease. It's a wonderful steroid sparing option, especially in a society which is so steroidophobic. Unlike other options, it is very safe in children as well as in pregnancy. And considering the cost, it is quite cost effective with excellent long term safety. And what we will see throughout this talk is that early intervention will provide better long-term outcomes, and phototherapy plays a big role in that. So why is narrowband UVB kind of the gold standard as far as phototherapy is concerned? One, it is the therapeutic spectrum that is 311 to 313, gives better efficacy, reduced erythema or erythmogenic reactions. No oral psoralins are required or topical. It can be a standalone modality that you can offer. And compared to PUVA, which is what we should be comparing phototherapy narrowband UVB with, it is a relatively safer option. So I would like to mention this particular study here, which compared the efficacy of psoralen UVA therapy versus narrowband UVB therapy. And the conclusion of this particular study was in narrowband UVB gave a better color match. Even after cessation of both the therapies, the superiority with NB UVB was maintained, which was not so with psoralen UVA. and a greater body surface area improvement with narrowband UVB. And not just that particular study, there are various such studies which compare these two modalities and where narrowband UVB fares a little higher as opposed to the other. Moreover, it is safe for use in children. It is safe in pregnant women, like we already spoke about. It is safe in patients with hepatic impairment where psoralen UVA may not be. There's absence of psoralen-induced nausea. There's no need of post-treatment eye protection and absence of the additional drug cost that comes with the psoralen UVA. So in our clinics, these are the commonly used devices that deliver narrowband phototherapy. You can have the full body chamber, you can have hand or foot machines or certain customized panels, which can also be used for in-clinic phototherapy. So how does narrowband UVB work? Basically what it does, it causes T cell apoptosis, it reduces antigen cell presentation, it reduces Th1, Th17 cytokines and increases the regulatory T cells and also normalizes keratinocytes. But this is in general how narrowband UVB work across all dermatologic indications, not just vitiligo. So narrowband is a immunomodulatory therapy, whereas everything else that we mostly use for vitiligo are immunosuppressive. So its mechanism in vitiligo, which we are trying to utilize it for, basically involves suppressing the autoreactive CD8 plus T cells, which are an indicator of vitiligo activity. It reduces interferon gamma, CXCL9, CXCL10, which are again responsible for progression of the disease. It activates melanocyte stem cells. It enhances melanocyte migration and melanogenesis, which is what we want, repigmentation, and has a great synergy, as we have recently over the last 5 years concluded, a great synergy with topical JAK inhibitors as well as oral JAK inhibitors. So currently our talk today is going to be primarily focused on vitiligo. However, narrowband phototherapy does find a place when it comes to treatment of psoriasis, atopic dermatitis, CTCL, LP, PLC, chronic pruritus, perforating dermatosis, and probably many more indications. So when we talk about vitiligo, what is an ideal patient who should be recommended phototherapy? One, generalized disease or progressive vitiligo, no leukotrichia, and a compliant patient. Compliance is very, very important. You want the patient to come in regularly for their sessions to get the best out of it. And what do you avoid or whom do you avoid? Avoid in photosensitive disorders. If the patient is unable to comply for whatever reasons, their job, the timings don't suit them, or a history of melanoma. So comparing clinic-based versus home phototherapy, now Dr. Dwivedi is going to take us through the details of how home therapy should be done and can be done. But if we have to compare, the clinic phototherapy is supervised, accurate dosimetry can be ensured, and it is ideal for initiation to start off the patient on the concept of phototherapy. But at home devices are also convenient for selected patients. They might be the best possible solution when patients stay far away from home, cannot travel to the clinic, far away from the clinic and cannot travel to your clinic and be compliant. This is a very good option, as Dr. Dwivedi will tell us, but it does require proper education. And if I take you through this LITE trial, it supports supervised home phototherapy and it can be as good as clinic-based phototherapy. So how do you assess a patient before you start phototherapy? First, be sure of your diagnosis. If you want a good outcome, your diagnosis has to be proper and you are doing phototherapy for the right indication. Assess disease severity as well as activity. Always, always, always take baseline photographs so that you can track improvement. Certain areas might not be visible to the in normal light. You can use your Woods lamp in such scenarios. Always review previous treatments or concomitant treatments that the patient might be on and assess compliance each time. What is more important when judging the response to phototherapy is patient adherence. Adherence predicts success of phototherapy. So make sure your patients understand the importance of being regular. Now, certain contraindications, as we all know, XP, DNA repair disorders, active lupus are absolute contraindications. Relative contraindications do include melanoma history, immunosuppression for other conditions, and photosensitizing drugs if the patient is consuming. UVB is generally safe in pregnancy and children, as we know, and there are many articles and research which says so. But whenever putting a patient on phototherapy, make sure you elicit history of consumption of these drugs: doxycycline, fluoroquinolones, hydrochlorothiazide, amiodarone, NSAIDs, and retinoids, as they might increase photosensitivity in an individual. Now, how do you prepare a patient? Now, patients are not aware what phototherapy is. The big full body chamber might appear scary to some patients. So make sure you give them a tour, you explain to them in detail, take your time so that they get comfortable with the whole idea of phototherapy. Ask them to remove their cosmetics and perfumes, remove jewelry before entering the chamber, ensure that UV goggles are put on, and ask them not to be tempted to open the goggles or see what is happening, as that might be detrimental to the eye. In case of male patients, make sure adequate male genital shielding is instructed. Record your treatment dose. Make sure you maintain your records really well, so patients can either have a treatment sheet which mentions their dose and the date on which it is given, so that they can carry it home with them. But you at your end as a dermatologist also make sure you have your record sorted as well. And post phototherapy, a big mistake which a lot of patients do is they take phototherapy and then go out in the glaring sun, and there is a chance that the redness might increase, or it might lead to itching, irritation, blisters. So please do advise sun protection post phototherapy to all of your patients, especially on the exposed areas. Now, children, yes, phototherapy is safe in children. However, they need to get a little bit comfortable. So make sure you ensure that, one, they are very comfortable when they go inside, or they're accompanied by an adult who can sit with the patient in the chamber for the first few sessions till the child gets a little comfortable. To shield the genitals, what we prefer using is a aluminum foil, easily available, disposable, and a very cost-effective option. Now, how do you choose the initial dose? When the patient comes in, you want to start them on phototherapy. How do you choose the starting dose? One, yes, you can do a MED-based assessment. However, in patients of vitiligo, it becomes a little difficult because MED on a white skin and a normal skin might be different. So what we prefer doing is the fixed dose. Okay, this is preferred for vitiligo. This technique is based on an individual skin type. So for example, somebody with type 1 usually starts at a dose of 150 to 200 millijoules, type 2, 200 to 250, type 3, 250 to 300. What we commonly see is between types 4 and 5, where the starting dose is 300 to 350 or 350 to 400. Now, how do you escalate the dose, or how do you hold the dose? Okay, so after your initial dose, if there is no erythema, then you need to increase the dose by 10 to 20%. If there is a mild pink blush similar to that on the nail bed, as pink as the nail bed, that means you found your MED or the right dose and you can maintain it on that. As you can see it in the image, this light pink blush is what we are looking for. However, if it is very red, very pink, painful for the patient, you can hold the dose and try and reduce it 20% if the symptoms persist. And if there are blisters, that means there's something wrong. You've probably gone over and above the recommended dose. So please stop and give a break for a few days. Once the redness, blisters, and all settle down, restart at a lower dose than what led to the blisters. Now, a lot of patients do end up going for holidays, going for vacations, and missing their treatments. So what to do about the dose? So if the break has been less than 1 week, you continue. You don't have to change. You escalate as per your original plan, increasing your dose by, say, 50 millijoules every second. If there has been a break of 1 to 2 weeks, then you need to reduce the dose by 20%. If there is a 2 to 3 week gap, then you need to reduce it by 25 to 50%. And if it has been more than 3 weeks, then you need to restart from the starting dose and escalate ahead. Now, what is the ideal frequency? How frequently should phototherapy be done? Ideally, 3 sessions a week is what we recommend. But for patients who cannot, even 2 sessions per week can be started. However, it will just take them a little while longer to get repigmentation as opposed to the thrice weekly sessions. Please assess every 12 weeks, comparing photos to see the improvement. If possible, you can also maintain the VASI score and see the improvement with it. And review after 24 to 36 sessions. Is there improvement? Is there no improvement? Are you at the right dose? So you need to keep evaluating at 12 weeks, 24 weeks, 36 weeks. Now, how long should one continue taking phototherapy? Like I said, first assess after 24 to 36 sessions. If there is no improvement, then probably phototherapy is not working. Maybe the patient has leukotrichia, maybe is not going to improve anymore. So phototherapy can be stopped if needed. Continue 9 to 12 months safely if patient is responding. And do not stop because of arbitrary treatment numbers. You know, our textbooks do mention 100 sessions, 150 sessions, 200 sessions. But there are reports and there are studies which have evaluated patients even beyond 200 treatment sessions, showing no signs of anything negative happening. So can be continued for around or more than 200 sessions as well, if the patient is showing signs of improvement thereafter. So ideally, if 24 to 36 sessions, you do your first efficacy assessment. At 6 months, you continue if repigmentation is still evident. 12 months, continue if improvement persists, otherwise you can stop. And for more than 12 months, you can individualize. There is no strict arbitrarily 12 months that you need to stop it. You see the patient and you can stop if a plateau of repigmentation is reached. And lifetime maximum, like I said, across various studies and research papers, it's not yet established and is considered safe even beyond that. So what is the current algorithm? For localized vitiligo, we would not prefer narrowband UVB. However, Excimer is a good option and we will be talking about that as well. However, for generalized vitiligo, it's a good therapeutic option. For active spreading vitiligo, again, it's a good option, but combined with our oral immunosuppressors to arrest the disease progression immediately. For suboptimal response through phototherapy, patient is responding but very, very slow. Maybe we can consider adding either a topical or an oral JAK inhibitor to kind of enhance the repigmentation. And if the patient is stable with some few residual patches which are not responding, maybe surgery is the better way to go ahead. There are certain predictors of response, good predictors, bad predictors. The face, neck, early lesions, hair-bearing skin, no leukotrichia usually tends to respond better as opposed to the hands, feet, lips, which are non-hairy areas. Presence of leukotrichia is a poor marker, and old recalcitrant lesions might also show a poor response. So again, when we talk about repigmentation can happen in different patterns. It can be perifollicular, it can be marginal, it can be more diffuse, or a mix of all of these, as you can see in the pictures. So talking about combination therapy definitely works superior to either of the individual modalities. So combination of tacrolimus with NB-UVB has a good evidence level and is generally preferred. So does NB-UVB with topical steroids, with OMP. And of late, we have a lot of great data coming up about the combination of oral and topical JAK inhibitors in combination with phototherapy working far superior to the other agents. Now, why does phototherapy fail in some people? Some patients might respond really well, some not as much. One, if your diagnosis is wrong, so you might need to revisit that. Leukotrichia, areas with leukotrichia are not going to respond well. Acral lesions are poor responders to anything and everything at the moment. Patient hasn't been compliant. If your UVB dose is low, you need to rework that and reassess that. Or if you end up stopping phototherapy too early, you assess the patient at say 6 weeks or 8 weeks and see no response and you stop it. Whereas some patients do respond a little bit later than that as well. And how do you optimize your results, get the best out of your phototherapy? Ensure you're getting in at least 3 sessions per week initially. Combine topicals which have an enhancing effect with the phototherapy. Serial photography is a must. initiate treatment as early as possible. Don't wait for later. People first feel ki, let me stabilize the disease first, then I will add phototherapy. But my advice would be to combine both at the start itself and ensure good compliance from the patient's end. So this is my practical protocol. Usually on the body, we start at 300 millijoules, 10 to 15% increments till we see a pink blush or a light pink erythema developing on the patches. And then we will hold the dose constant for a while, ensuring 3 sessions a week. Especially for the face, I love to combine phototherapy with topical tacrolimus or topical tofa. And if the disease is active, only phototherapy might not suffice and patient will need oral immunosuppressives, and assessing at 36 sessions to see for the response or a plateau in response. Now, coming to the next modality which we offer in our clinics is the eczema phototherapy. It delivers UVB of the 308 nanometer spectrum only specifically to the lesion to be treated. So higher therapeutic doses can be delivered. There is faster repigmentation as opposed to phototherapy, narrowband phototherapy. And the big advantage here is that it spares uninvolved skin. So a big negative about full body phototherapy is that there's a lot of tanning which happens to the uninvolved skin. So this is one way to avoid that. However, it is ideal for localized vitiligo only and not on multiple spots all over the body, where we would prefer the full body chamber. So mechanism of action is same as our narrowband phototherapy. What are the best candidates for eczema? Lesions which are present on the face, on the neck, new lesions, early segmental, focal vitiligo. These are good candidates for eczema therapy. Again, poor is the same: hands, feet, lips, leukotrichia in the lesions, or extensive disease which is not conducible for eczema treatment. So what is our treatment protocol when it comes to eczema? 2 sessions per week preferred, but we have data coming from Dr. Imran Majid, who actually gives 1 session a week with good response for patients who don't live close by and can't travel to the clinic twice a week, leaving a gap of at least 48 hours between 2 sessions. Either you can start treatment through the fixed dose, which is what we prefer in vitiligo, or the MED-based one. Increase by 10-20%. Assess the response at 8 to 12 sessions, maximum 30 to 60 sessions. If you don't see any response, that means you need to look at other ways of repigmentation. So remember, when it comes to phototherapy, consistency is more important than protocol. So again, combining things with eczema will definitely enhance the phototherapeutic effect. Eczema with tacrolimus has a lot of data and studies. So does eczema with topical steroids. And of late, we've been combining topical tofacitinib along with phototherapy. So these are a few of my cases which have done really, really well with topical treatment and phototherapy. Now, comparing eczema versus whole body, where would you choose what? Eczema for localized disease, higher lesion doses to be given in some areas, then we would prefer the eczema. However, choose your NB-UVB for more generalized disease. However, both of these modalities are complementary and can be used together in a same patient also, where you feel one lesion needs a slightly higher dose compared to the rest of the body. Adverse effects of both the types of phototherapy can be erythema, blistering, hyperpigmentation, pruritus, very rarely burns, but if you've not chosen your dose wisely, this does happen and needs to be managed appropriately. And certain practical tips, we've already mentioned them previously. Photograph every 12 weeks. Please don't stop phototherapy once you start noticing perifollicular pigmentation. Please continue even after that, because the pigment does tend to spread better. Please combine with tacrolimus or other topicals and orals wherever you deem appropriate. Avoid underdosing and ensure proper eye protection wherever applicable. So again, not going to repeat this slide. Let's talk about the role of phototherapy before and after vitiligo surgery. It is a very, very important and fantastic adjunct to enhance the results of your vitiligo surgeries. It also helps stabilize disease before surgery. So it's a stabilizing agent in that case. It improves your donor bed. It stimulates melanocytes. So if you want to take a graft, it will probably give you a good concentrate. Start phototherapy or eczema after vitiligo surgery, after the epithelialization has been complete, to make sure that the pigment cells that you've put in through the graft or your cellular suspension get stimulated and spread better and faster. And you can continue it for 3 to 6 months after the surgery also to enhance the pigment spread further. In some individual, phototherapy fails primarily because of poor compliance or poor patient selection. So most failures, like I said, are protocol failures or incorrect correct patient selection rather than the modality itself. So certain key home take home messages that it remains the cornerstone therapy. Eczema complements localized disease and combination therapy is increasingly standard. Make sure that patient selection and adherence to treatment is followed properly. So the future of management of vitiligo is not in surgery or medicine, medical or phototherapy alone, but a combination of all these things, three things together. So I hope that was useful. Now let us hear a little bit about home-based phototherapy as well. Thank you.
Thank you, Dr. Madhulika. That was an excellent talk. Excellent, should say. I've learned so much in the last 20 minutes. Was really, really awesome. We'll take up some questions pertaining to your talk, and then we will move to Dr. Divedi. So we have a question from Dr. Shreyansh Singh from Jamshedpur. What are your inputs and clinical experience with decapeptides, Dr. Madhulika?
Uh, so I don't use decapeptides too much unless my primary modalities of choice, that is topical tacrolimus, topical steroids, or topical JAK inhibitors, have failed. However, there is a lot of data which says that a combination of decapeptide with phototherapy tends to work better than either of the modalities alone. So yes, if you feel you're not getting adequate response with your topical tacrolimus or other topicals which are conventionally being used, you can add decapeptides to the regime.
But what's your real core experience with decapeptides, Dr. Madhulika? Because
It works really well in hair, like non-leukotrichal areas. But if you have to compare it with tacrolimus, I still feel tacrolimus is slightly superior and helps me stabilize the disease as well as repigment it.
okay, so the take home is that tacrolimus will help in stabilization and it's a better molecule. We have Dr. Prerna Jha, Purnia. So her question is, what is your take on excimer lamp versus excimer laser?
I don't have experience using the laser. It's a very, very expensive modality. But in clinical practice, using the excimer that lamp that we have been using for a while, the results are excellent. So I don't think you need to invest so much in
Correct,
getting the
correct.
excimer laser. It's not worth it. So stick to the lamp. Very good results as long as your patient is compliant with treatment.
Thank you. Yeah, I think I'll second you on that. Laser is obsolete now. I mean, there's no point in spending 35, 40 lakhs when you can get a decent machine. And there are enough papers which have been published to support this also. One more question. Dr. Aprajita Sahagar is asking, at what age can NBUVB slash Excimer be started? So that's a good question.
So the reported, as far as like research articles and all is concerned, it's 2 years and beyond. So it's just about the patient being comfortable in
Yes.
that whole scenario, and the patient's caregivers or parents accompanying the kid into the chamber. The youngest patient I have at my clinic on phototherapy is a 3-year-old boy who's loved by my staff. But there is apprehension for the initial few sessions, but then they tend to get used to it and comfortable with the whole scenario.
Okay, there are a lot of questions coming in, but so we're going to take all the questions in one by one. But I let's go over to Dr. Ravi Shankar Devedi now. Let's hear him talk about home-based phototherapy, which it's booming late. It's a late player. It's a wild card entry in my opinion, but it's a very very underutilized treatment in our practice, and I'm very very excited to introduce Dr. Ravi Shankar Devedi. He's director and chief consultant at Shanti Skin and Laser Center at Ranchi. He has numerous presentations. He's an excellent teacher. We have heard him teach, and he's a member of BFI. And he just says I'm a regular member of IDWEL, but he conducts a lot of workshops. And every year on World Vitiligo Day, for many years, he's been conducting workshops and spreading the knowledge. Over to Dr. Divedi. We're waiting to hear from you, sir.
Yeah, thanks, Dr. Munish, for the generous introduction. So coming to this home-based phototherapy for vitiligo. One second. Is my screen visible?
Yes, sir. You
And I'm
can make it
audible?
full page now. Okay.
One sec.
Perfect.
One sec, just. Okay, so thanks, Dr. Madhulika, for a wonderful presentation. In fact, you have made my work very easy. So whatever advantage, disadvantage, predictors of response, combination of drugs, whatever Dr. Madhulika has said applies to home-based phototherapy also. So, I practice in Ranchi. It's a small city in Jharkhand. And it's a beautiful city, best known for its waterfalls, and then is the home city of MS Dhoni. So I've been practicing vitiligo since last almost 20 years. And this is how the brief structure of my talk, a brief introduction to vitiligo, what is the role of phototherapy. I guess Dr. Madhulika has taken all this already. So I just rushed through the slides. We know that vitiligo is a melanocytopenic disorder and immune system has a major mediator in that. And phototherapy, it works not only by immunomodulation, but also by increasing the expression of, proliferation and migration of melanocytes. So it has been established beyond doubt that phototherapy is the treatment of choice for vitiligo, the gold standard. And I'm going to say that this home-based phototherapy is just an extension of institution-based phototherapy. It's not different from that. What I'm going to tell you is introducing you to the practical aspect of incorporating it in our day-to-day practice. So this is an ideal intervention. If possible, home-based phototherapy, the institution-based phototherapy is ideal. We can always, monitor the dosage, schedule, compliance. Any adverse event can be readily addressed and managed, and chances of overdosing and overtreating are minimal. But the problem is the issues with institution-based phototherapy. You just imagine you're practicing in a big city. Now, to have a phototherapy setup is a real big investment for the clinic. It has a large real estate footprint, so at least you require 120 square feet area, dedicated area. And then it needs a good power backup, minimum 3 kV power backup. You need a dedicated staff. And there's high input cost in terms of tube replacement and power consumption. These phototherapy tubes, they are meant for 100 hours of exposure. Okay, after that, their irradiance starts decreasing. So I'll give you a simple example. We have around 30 settings per day in my setup. Okay. And if you take an average of 2 minutes of per patient, it means that by 6 months, but that my tubes are starting to degrade. And at the end of year, at least, or max by 2 years, I have to replace them. So that comes to around 2.2 to 2.5 lakhs, just changing the tubes if you want to maintain the results. So this is for the clinic and institution. Once you think about the patient, just imagine, see, for any chronic therapy, like minimum 100 to 150 sittings, the patient has to, come for the treatment to your center. Now, for all these long treatment periods, and the response is slow. So the patient apathy, the fatigue is going to set in, and there's high investment in terms of travel and time. So for that 2-3 minutes of therapy, the patient has to travel 2 to 3 hours. They have to have a loss of work at least half day. If it's a kid, the parent has to come with the kid, and they have to miss their classes, their tuitions, and all the things. So all these things. So with these practical problems, the compliance with institute-based phototherapy decreases. So what we can do, we have this option of home-based phototherapy, and it's not a new thing. It was introduced as back as 1979 for the treatment of psoriasis, and by 1990s, it was adapted for vitiligo. Now, it reduces the logistic burden on healthcare provider as well as the patient. And it has been proved in several studies that the patient undergoing home-based phototherapy, they're more compliant. Just imagine a female having this vitiligo on their private parts, the ability to take it at their own time, at their own convenience. And most of the times, they don't want to let their in-laws, their family members know that they have vitiligo, because that is a social disease in my part of the country, at least. So at 10 o'clock in the night, when everybody is asleep, she can take conveniently in the affected area. Or maybe a 3-year-old kid who's not going to sit comfortably in the front of panel or in the whole body machine. When the kid is asleep, the parent can comfortably and conveniently give the phototherapy at home. So, and if monitored properly, this home-based phototherapy is as safe as institution-based phototherapy. So, but what are the major constraints? Why we are not using it as frequently as we should be using? Now, what I find the most common is physician awareness. There's something like cosmetic camouflage. We know about this, but we rarely offer it to our patients. Or during my training in dermatology, like us, hardly I prescribed home-based phototherapy to any patients, neither my teachers prescribed. So what we practice is majorly what we have learned in our institute. Okay, we may add to that, but that remains our basic skeleton. So there's a major physician awareness problem with this home-based phototherapy, and we have to educate our community that look, this is a good modality. You can practice it. Your patient can get advantage of this. Now, the next concern is our safety and efficacy. We are always afraid कि patient will overtreat themselves. अपने आप को ज़्यादा कर लेगा, जला लेगा. ऐसा नहीं होता है. If you explain properly, it's very simple. And then there is initial investment barrier कि शुरू में बहुत खर्चा हो जाता है. I'll talk about that later. We have some more issues like the patient may not follow the correct procedure, or not using the right doses, missing or over-treating the areas. And then again, the concept of patient fatigue. If not monitored, they will feel that एक बार पैसा invest कर दिया, खरीद लिया, काम खत्म हो गया. उसके बाद, they start missing the doses and they start forgetting and they start blaming us कि हाँ इतना पैसा लगा दिया और फायदा नहीं हो रहा है. So these are the basic problems. But then we have to find a solution because this is an excellent modality. So, I'll tell you how I practice home-based phototherapy because I practice it extensively now. The problem of, practicing in small cities, you have to work in a resource-constrained setup and you have to have the attitude of a street practitioner. So I've evolved and refined my system over the last 20 years and I'm going to share that with you. So initially, I was getting these UVA lamps and panels and combs. That is in 2007-8 when UVB was not that easily available. But once it became available, I'm now extensively using this narrowband UVB for home-based phototherapy. And we have a dedicated teledermatology section. Another irony of small cities are we lose the entire generation to the metros. बच्चे हमारे बाहर पढ़ने जाते हैं, then take the job and move there. But then they carry the memory of their house and their doctors with them. They are not comfortable in the metros की आप लोग कोई दिखाना है. And thus we have a dedicated teledermatology center. Like every day we practice around 2 hours of teledermatology, and we have a dedicated nurse for that. So that nurse is in charge of my home-based phototherapy section. Now, how do you select a patient? So all the absolute and relative contraindication for office-based phototherapy, that applies to home-based phototherapy. All the genetic conditions, all the photosensitizing drugs, which will rule out your office-based phototherapy, same will apply to your home-based phototherapy. This very important is screening for photosensitizing drugs. Although we read about this, but we commonly miss it. So most of the teenagers, they are taking doxycycline for their pimples. The adults, they are taking antihypertensive. Now this hydrochlorothiazide is one of the most common combination with telmisartan and other certain group of drugs. So most of them, they are taking this. So we have to be aware about their antihypertensive drugs or the other drugs which may cause photosensitizing. And then we need to have a motivated patient or a caregiver who understands the procedure, who's ready to follow. So who's my ideal patient for home-based phototherapy? Any patient with less than 20% body surface area involvement and is a candidate for institute-based phototherapy. I will offer this home-based phototherapy to the patient. Any newly diagnosed patient with small patch, in infants, in children, in pregnant and lactating mothers, this is probably the first thing which I offer to my patients. Now, any patient who's motivated enough, who understands, the periodic dose increment adjustment, how to adjust for the missed doses or how to early identification of side effects, he is a candidate. So this kid came a week back to my clinic, a 2.5-year-old child. He had this segmental vitiligo for 3 months duration, which is rapidly spreading. So he is like one of my ideal patients for home-based phototherapy. A small machine will definitely cover the entire area and help this kid. So these are the different type of home-based phototherapies we offer: small panels, then hand and foot unit, this combs, and of course a couple of doctors and the rich patients who can afford, we give Excimer as well. So how can we improve the compliance? That's the most important part. So I've understood that the single most important point which decides compliance in any chronic therapy, maybe hypertension, diabetes, HIV, is the ease of treatment. That's how the concept of poly pills came, combination pills came. So again, this home-based phototherapy is making it very convenient, but we have to make it more convenient for the patient. We have to design it in a very interesting way so he looks forward to it. There should be periodic monitoring by the teledermatology nurse, checking for missed dose, side effects. We ask for short videos, photos of the lesions so that we can tweak the doses. Now, another problem is if the patient has got multiple sites. Okay. So if the treatment duration goes beyond 15 minutes, no, the compliance is going to be compromised. No one can sit in a place for more than 15 minutes every other day to take treatment for 1 hour or half an hour. So what we do, जैसे जिम में करते हो कि एरिया डिवाइड कर दिया, आज मैंने आर्म मारा, चेस्ट मारा, कल लेग एंड लोअर लेग बैक करेंगे, तो वैसे हम लोग मंडे वेडनेसडे फ्राइडे वैसे अपर एक्सट्रीमिटी एंड चेस्ट, and Tuesday, Thursday, Saturday, lower extremity and back. So what it does is it divides the treatment in two parts. So patient को short time packet invest करना पड़ता है 15 minutes per day, and then they can take it conveniently, comfortably. So the Vitiligo working group says that the optimal doses are 3 times per week, acceptable twice weekly. We explain and offer this to this patient. The dose increment, we cannot follow the millijoule thing. So we have to give them time-based. So I'll come to that in my next slide. So what we do is we empirically start, say, around 30-second exposure. Okay. And there's 5-second increment per session. The end point is a mild faint erythema, which reaches maximum over 8 hours and disappears by 48 hours. If it, remains beyond 48 hours, it means our dosage is high. We have to decrease the doses. The maximum dosage is around 3 minutes on the face and 5 minutes on other body parts. So what we do, we provide a dose card to our patient and then we give a handout to the patient. And I'll just read it out for you guys. So we ask the patient to keep the machine around 1 inch from the lesion. This applies for the comb. For the panel, it's around 1 feet. We set the timer. What we do is, along with the kit, we give a small kitchen stop clock to them. Okay, that costs around 200 rupees. So because patient क्या करता है, हाँ मैं 2 ही मिनट ले रहा हूँ, and वो अंदाज से लेता है, तो that does really spoils the things. So add that to the kit, that small stopwatch, so they can fix the timer for given duration of seconds, and they take it. So they take therapy in the alternate days. For the kids, what we do, we give a monthly planner along with that star stickers. You get for 5 rupees, you get 20. And then every time the kid takes it, he puts a star on that day. So the kid feels very happy that I've achieved this something, It's like positive reinforcement. So we have designed many such things for the kids and even for the adults to make it interesting. So they have to increase their dose by 5 seconds with every subsequent doses. Now, number 6, you see, if there is any redness or itching at any dose, then it is advised to skip one dose. Okay. Then go back to the previous dose, continue same for next 5 settings. And once you are comfortable, then again start the increment by 5 seconds. At whatever dose, again there's erythema, then go back to step 6. Like you have to skip one dose and go back. So this is how we do it. Now we specifically tell it's a medical device. It has to be used as per the advice of the doctor. And then you have to give a hotline number, which in case of emergency or side effect or the problem, the patient can always get back to. That gives a lot of confidence to your patients कि अगर कोई दिक्कत हुआ, so there is someone at the other end of the phone. Now you have to make it financially appealing for the patient. So cost can be brought down if you order in bulk. Like for this home-based combs, narrowband UV combs, I get for around 5,000 rupees per unit. Another thing I've realized, we give them the buyback option. The moment you give the buyback option, the patient feels कि ये तो ठीक होता है और डॉक्टर वापस ले लेगा. Like I'll tell you, last 15 years of my practice, hardly 20 units have come back. But then once you give this option, they feel very happy. So how we follow is 40% depreciation is the first year, followed by 20% every year. And if there's a tube fuse for the panel, it's like 4,000 for one tube is deducted. Now, what we do with the return products? Now, we have a charitable wing to our clinic. We do some charitable MKT surgeries also every month. And for those needy patients, we give them free of cost, those whatever units you get. Or the other thing we do is, for my post-surgery patient, like MKT patients, smash grafting, punch grafting patient, I give this home-based phototherapy unit for 2 to 3 months. Now, that drastically has improved our results. And those patients, they give it back after 2 to 3 months once they have got adequate pigmentation. So by giving this option of buying back and returning, it increases the confidence of the patient in your treatment and they find it कि अच्छा ठीक है बहुत ज़्यादा पैसा नहीं लग रहा है. Now, even we doctors have this mental barrier कि बहुत expensive पड़ता है. But let me give you a simple example. For any vitiligo prescription having a immunosuppressant, an antioxidant, a calcium inhibitor, and a basic like decapeptide, the cost is around rupees 5,000 per month. And this small comb comes for around 8 to 10,000. So it's not very expensive if you think it that way and explain it that way. Now, how do you monitor the home-based phototherapy? Now, this is the most important part. So we provide a dose card. We have a dedicated phototherapy nurse. She maintains pre-treatment photograph. Now, at the time of giving the equipment, we add a small timer, as I said, to the kit. Now, we have to learn to analyze the data. We should never trust the patient with data. We learn to see the discrepancies, and we can make out, okay, that this patient is forging their data. We have to train them to give phototherapy properly, maintaining the right distance. And the most important part is like this, how the patient sends us pictures, how they are taking their home. While selling the machine, we always add a package for video consult for the machine for the first 2 months. So let's say अगर machines को 8,000 का जा रहा है तो को 10,000 में पैकेज हम लोग देते हैं ताकि initially every month we'll have a 10 minutes video consult with my teledermatologist sister. She will see how the patient is taking the treatment, explain properly. So that reinforces it, and after 2 months, we make it every 2 months. The patients, they are requested to send videos and photos after every 10 sittings. And like जिस तरह attendance book होता है ना स्कूल में, we have for the patients, and sister has a schedule कि आज किस किस को call कर रहा है. And at the end of the month, like we discuss about all the patients. It's not that we just sell the machine and forget about it. Every month we have a discussion about all our home-based phototherapy patients. And if required, like I take a video call with the patient. So to conclude, this home-based phototherapy, this is an excellent but an underutilized treatment. Both physician and patient awareness is required about the home-based phototherapy. Every suitable patient should be given the option of home-based phototherapy. We should not take decision in the place of patient. We should give this option to the patient and let him decide. The safety and efficacy is at par with office-based phototherapy. The convenience is far outscoring. The good monitoring system has to be in place, and it should be presented as a good financial package to the patients. Now, this is a small township near Ranchi, Makluski-Ganj. Pre-independence days, this was the settlement of Anglo-Indians. It has this pre-colonial vibes, the colonial bungalows, small rivulets. So whoever wants a picnic, come down to Ranchi. I'm happy to accompany you. Thank you.
Thank you, Dr. Dwivedi. That was a wonderful talk. And, the concept of home-based phototherapy has been exemplified by you. And the best part, what I liked about is how you give those, hand units, how you have your sister, to manage the staff nurse, to manage everything, and the buyback, and, the way you've said about the depreciation value. I think that's amazing. I think we all, whoever's listening to this, can start doing this. I always give like the numbers of patients, tell them this is the vendor's number, call and find out. But this system of you giving it and following up with those, video calls afterwards and with photos, that's amazing. So thank you for sharing your superb tips with us. I would like to take some questions that have been coming. We have a lot of questions that have come up. So this question is by, what is the so this one thing is on home-based phototherapy. I wanted to say, how did you measure that when you want to start with home-based 300 millijoules? How do you fix the time duration in your unit? Have you measured how to measure that 300 millijoules?
Yes, initially we tried to do with that UV meter, but it's very difficult to standardize. So what empirically we start with 30 seconds, and within 10 settings, the patient start achieving that faint erythema, which is our endpoint. So that is how we have to go empirically. We can't be very rigid about the millijoule doses. That's what.
So in the units which you've been giving, you find like around 10 seconds is where you get
30
the
seconds, I
miles.
start with 30 seconds and 5-second increment every sitting. So
Superb.
normally
So
most of the patients by 70 seconds, 75 seconds, they start getting that erythema thing.
Okay, great. So also this is one question I want, because we are taking home-based phototherapy. Let's complete few questions of home-based, and then I'll get Dr. Madhulika also to take some of the other questions too. One home-based phototherapy question was that you said you gave a timer with
Yeah.
it. So the timer is what, in seconds, in a digital timer? What do
Seconds in
you give?
digital, we get kitchen clocks or the sports shop, you get
Yes.
this 200 rupees ka timer. So,
Okay, great. So that's
so
what you also
Ten
add to
30, yeah,
your.
that's 200, comes for 200 rupees, but then that makes things very easy because if you leave it to the patients, हाँ मैं 2 मिनट लिया, अब वो उसको मोबाइल में देखने में कभी रील्स देखने में तो 2 मिनट का 2.5 मिनट हो जाता है. Calm
Correct,
things make it
correct,
very
correct,
easy.
correct. Okay, so now I'm going to get both of y'all, and anyone, or Dr. Munish, you can also contribute wherever you can. There are some questions that how this is by Dr. Manjiri. Madhulika, do you measure the VASI scoring of the face and neck or any other scoring before starting, whether home-based or clinic-based phototherapy?
I think in day-to-day OPD, it's very difficult to measure and adhere to a scoring system. So no, I don't use any scoring system. I rely on serial photography, normal light, as well as Woods lamp photography to compare and assess my response to treatment.
Okay, anybody else wants, Dr. Munish, or you want to
I,
add? Do you
I
do any other special scoring?
I think the various scoring methods are available, which are essential if we are doing a trial or a study. But as Dr. Madhulika rightly mentioned, and we are, the idea of this webinar is practical take home messages, and, people in busy OPDs and dealing a lot of patients, and unless you are in an institute based practice, then, it's more simpler to follow it up. But for practical purposes, I think most of us are relying on serial photography, which is important. I'll just have a small thing. I always ask the patient to take photographs themselves. It's very difficult for us to keep maintaining so much record. Otherwise, you need to have systems to retrieve those photographs, then see them. I find it much easier for a patient to start maintaining. So I tell them make a folder, put it on the cloud. So it becomes much easier. It's a simpler way, and the patients are very dedicated about it.
Dr. Ravi Shankar, any tips
No,
for
I fully agree with
monitoring?
this because what the
Ah,
patient, once the patient takes the pics and they send to us, we have like that WhatsApp number where they send it. So once we go back, we can have all the photographs on that patient on that particular number. So
okay. I would just like to add that, once we recently attended the Chandigarh conference, and, there was a talk on the future. So there is this Image J software which might help you to take photos and calculate
yes, we've
VASI
seen
also.
that. That was
So,
interesting.
I think it's going to come in. Maybe, next webinar we'll be talking on that, how we are all using AI. So I think very soon. Okay. Then there is one more question by Dr. Shiba Mariam Jacob. What is the maximum recommended dose of narrowband UVB light for type 4 and type 5 skin? Madhulika, would you
Uh,
like to take that?
so maximum recommended dose, ideally, like we divide it as the face and body. For the face, it is somewhere around, I think, 1500 millijoules, whereas the body can be between 3000 to 4000 millijoules. But
Okay.
like I said, there is no like evidence that you can't go beyond it. You see the patient's response, and that's how you are going to escalate. But yeah, like as per expert consensus guidelines and all, it's between 3000 to 4000 millijoules.
I'd
Doctor,
like to add one
yeah,
thing, Dipti.
Yeah, Dr. Divedi.
yes, yes, yes.
So, our phototherapy machines, what we use in our setup, okay, we don't have something to measure the
Yeah.
doses. Now, with passing time, the efficacy decreases. Now, what I get with 3 joules in a new machine is not the same which I get after 1 year. Okay, so ideally, either we change the tubes to get the same efficacy, or we, you know, empirically increase the doses. So, what I was earlier with 3 joules, I'll go to 5 joules. So
Yeah.
that comes empirically, that you know your machine, you understand your machine, you see the response, and you have to increase the doses. So don't always go by the meter.
Okay, that's a good tip. Dr. Munish, yes.
Yeah, so this is for everyone. So understand when we're trying to stimulate the melanocytes, okay, so it's like riding a horse. Okay, understand the concept. You want to just nudge the horse for it to move. You don't want to whip it so hard that you kill it. So that was in continuation with the previous question, what's the maximum dose? You don't want to cause lysis of your melanocytes. If you understand, patients who keep taking phototherapy for a long time start developing these pigmented patches like IGH like lesions. It's like a fatigue. Your melanocytes can get fatigued. Understand that. You just don't want to push them. You don't want to kill them. So, there's nothing like so a faint erythema, as Dr. Devedi and Dr. Madhulika mentioned, mild erythema at 8 hours, so beautifully discussed by both of them. Fading out at 48 hours, that is what we need to do. Dr. Divedi, do you also give them printouts and handouts in Hindi and other regional
Yeah.
languages?
In Hindi and English, we give them.
I would request that you share them with the group for the benefit of all the
I'll
doctors.
share
It will
it.
be really,
Tomorrow
really
I'll
good.
share it.
It was a wonderful talk and we really appreciate. Yeah, Dr. Deepthi, please continue.
No, so also one question for Dr. Dwivedi. Is there any maximum dose of what you tell your patient? कितना minutes ले सकते
3
हो
minutes and 5
maximum?
minutes. For face, 3 minutes, and for body part, 5 minutes. Not to go beyond.
Beyond that, you don't tell them to take. Suppose
No.
acral areas and all 15 minutes. I have patients who come tell 15 minute लेते pink नहीं हो रहा.
वो नहीं सही करते. Like the way Munish said, they'll go in fatigue.
Okay. Maybe the distance, because I saw
Yes.
your distance was 1 inch. I
1 inch.
usually was maintaining 6 inch. So
No,
maybe
so
that could be
see,
the
the
reason why you're
diverges,
getting
light
faster
diverges
results.
and the energy becomes less. So for the comb, it has
Yeah,
to be
so bigger comb is only 1 inch.
1 inch, and with the panel 1 feet. So that we have, initially like in 2012, 13 के आसपास में, I had a meter to measure the doses and all. So we calibrated it to see कि कहाँ पर I'm getting optimum focus.
Okay. So now, any best brands for home-based phototherapy? It's going to be fast, so we can just
Yes.
say
So there's only one company in the world which make the tube, that is Philips from the Holland plant. So we get the tubes and rest I get fabricated, so I get, at a better price.
okay.
You're
So
using the
Dr.
6
Dwivedi
feet.
makes the best
Sorry.
brand now.
Sorry. So do you use a 6 feet tubes, Dr. Divedi?
2 feet. 6 feet, I'm getting one, like by next month, probably I'll be able to show you guys 4 and 6 unit of 6 feet tubes.
So
But right now I'm using 2 feet
currently, what
tubes,
is the length of your UV
2
tubes?
feet, 2 feet tubes.
So
For the
2
panel,
feet
you have 2
The
feet.
panel.
But are they TL01?
Yes, tier 0.
So TL01.
TL01 is 6 feet ones,
6
but there are
feet.
some,
But 2 feet,
yeah, they are
I
6 feet.
don't remember that, but it's made by Philips, that same.
Yes, that's correct. So they have a different code for the 2 feet, but
But
it is the same like TL01, but TL01 is specifically for the 6 feet one.
6
So
feet.
getting one designed with 4 and 6 feet tubes in a little curved manner. So I'm just working on the price of that. So probably by next month we'll have that.
Do you give them UV
Okay.
glasses also, Dr. Divedi?
Yes.
Which company?
Okay.
How do you decide about that? Practical tip?
वो
B2
kit के
toric?
साथ में, see, any beta toric glass.
B2 toric.
So even though your cataract glasses जो आपको 70 रुपए के मिलता है, even they are beta toric.
Or Ray-Ban.
So,
That is the
Dr. Dwivedi,
limit.
one more question. How do you decide which kind of phototherapy unit you will give which patient?
Yes.
The area involved, it's a small patch, the comb. If it's a bigger patch, single panel. It's a much bigger patch than the hand foot unit, 16 units. Again, the affordability, if the patient can afford which machine. So there are quite a few variables which come in picture which we have to decide.
Okay. If your phototherapy patient, home-based phototherapy patient is taken a gap, do you do same thing that you reduce it to
Yes.
again?
Yes. Now, I'll tell you one interesting thing with this home-based phototherapy. That gap part is less with that. अभी वो travel पे भी गया है ना, they can carry that comb with him. कहीं वैकेशन में गया, he can carry. शादी में गया, he can carry. जो हमारे इंस्टीट्यूट में नहीं आ सकता है, he can carry that. So वो breaks मेरे को कम होता है home based में.
Correct. That's the advantage of home-based. Then also, if you have an eyelid lesion, do you recommend home-based or do you not recommend?
Yes. Once, like mostly in the kids, when the kid is asleep, because it doesn't penetrate beyond 1.5 millimeter depth. So it's not going to reach the.
So, and number of hours, how do you track that patient has used how many hours?
So
You said
that
100 hours is the life of that one comb.
100 hours is a lot of time, I'll tell you. The maximum patient take is say 5 minutes. ठीक है 1200 exposure 1200 को समझ रहे हो आप कितना दिन होएगा? That's for over 12 years.
Okay, fine.
So that's
So,
then in home base they never achieve that. In our institute, since I have 30-40 patients daily for phototherapy, we achieve that. But in home base, you never achieve that 100 hours.
okay. So somebody, Dr. Raju is asking that he is using narrowband UVB phototherapy. Is it okay or you want to recommend anything?
Sorry?
He's using Derma India narrowband UVB phototherapy. Is it okay?
See, all of them are using the same tube. Whether
The
it's
tubes are the
Derma India or
same, so
Tubes or whoever. They are using the
combination
same
not
tube. Tube
really
supply is
matter.
just one.
Tubes should matter, yeah.
Dr. Madhulika, any maximum dose with the eczema?
Ultimately, we are looking at blush pink erythema. So, once that is achieved, if the patient aage jaake ceases to get that pink thing because of tolerance or for whatever reason, then you escalate. But I don't have a specific number to give them there.
Okay, perfect. So I think we've got end of the questions that we have. Some questions were there on which are beyond phototherapy. I'll take three questions of those. Like one question is on acral vitiligo. How do you look at it, and do you use phototherapy? You all can, Dr. Madhulika, you can start, and Dr. Ravi Shankar, you can also add.
I know acral vitiligo is the worst form of vitiligo to try to repigment. However, we don't give up. We will attempt to repigment it. My modalities of choice would be topical tacrolimus, topical steroid, along with phototherapy. I would try to observe for at least 3 to 4 months for any response. But if no response beyond that, then I will just continue my topical tacrolimus to maintain those patches at least, and then probably try a surgical modality if that is something that the patient wants.
Dr. Dr.
Yeah.
Dwivedi.
Yeah, fully agree with Dr. Madhulika. Beyond 3 months, there is no point in continuing, any phototherapy treatment. We just have to wait for the stability so that we can plan our surgery.
Super. Then one question was on, tacrolimus or pimecrolimus. Just choose one.
Tacrolimus.
So tacrolimus. Okay. What do you do for leukotrichia if not narrowband UVB light?
Surgery.
Dr. Dwivedi?
Fastest
Yeah.
finger first.
Too good. So I think we've got most of the questions covered. If I have one question, I'm going to ask Dr. Madhulika. You mentioned to save the male private parts in the narrowband UVB. Suppose they have genital vitiligo, and so you don't give
There
Excimer
are
there, or you
papers
don't.
which say that it is safe for the genitals also, but there are a sect of patients who are very, very paranoid about taking phototherapy. So you counsel them accordingly. If there are no lesions on the genitals, so you cover it. But if there are, then you don't. It's okay. There are studies which support that it does not penetrate, like Dr. Dwivedi mentioned.
Yes, like
So
what
the
we say.
consensus is we can give phototherapy in the genitals also, because even I use Excimer on the genitals, and I think a lot of us are using. I think so. I think it's okay to use it.
Okay.
Yeah, Dr. Dwivedi, you're saying
That's what I
something.
think. It doesn't penetrate beyond 1.5 millimeter. And there's skin, then there's a dartos muscle, then there's tunica albuginous, a lot of things before the testis. So it's well
Wow,
protected.
revision ho gaya, sir.
Wow, revision of anatomy.
Yes.
It's like if you want to cover, then you can use an aluminum foil, which is a disposable.
Actually, a couple of weeks back, I had, एक डॉक्टर से ही काफी कंट्रोवर्सी हुआ था इस पे, तुम क्यों देते हो वहां पे, तो मैं उनको समझाया कहाँ कहाँ है क्या क्या.
Nice, nice. That's a good take home for all of us. I think both of y'all can give a good one message for the audience as a take home, and then Dr. Munish can, take it.
Yes, my message is offer to the patient, let the patient make this decision rather than, not offering this home-based phototherapy.
Wow, nice.
I would suggest that you start phototherapy early. Don't use it as a last resort or a second option. It should be right there at the first visit, along with your orals and your topicals. And now we have an option. If the patient can't travel to the clinic, you have home phototherapy as an option. So you should at least be offering it to your patients. No excuses.
Yes.
Okay.
I'll take it, and then Dr. Munish, you take it, and then you
Yeah.
can give the closing. So I would like to. There was one last question which came view on Puvasol. I think Dr. Madhulika covered it beautifully on Puvasol. Just the thing is about the amount of soralane that have to be taken, and if the patients abuse it, there are chances of cataracts and liver issues and all. So if you have the option of narrowband UVB, the Puvasol, I mean, is a good option if they don't want to buy home base, if they are really poor and they want to do, then it's some option. But be very careful with the soralane use is what my message is for Puvasol. Dr. Munish.
Few questions for both the panelists. I'm not letting you go. Okay. So, Madhulika, you mentioned that you have a patient of active vitiligo. So, would you give it in I mean, Dr. Devedi, you can also comment after Dr. Madhulika. So, if you have a case of progressive vitiligo, would you wait for some time before initiating UV and start some stabilizing molecule as a first step and then add phototherapy? Or you think phototherapy is, in your opinion, more stabilizing than cobnarizing? What is your thought?
I don't think it is cobnerizing in all patients, but if they do give me a history of, sun exposure, probably giving them new patches, then I would not start phototherapy in that patient initially. However, for those who are not, oral medications to stabilize along with topicals and phototherapy, I would start personally straight away, because I think after 3 months or so, phototherapy itself will help me with the stabilization part, so I can wean off my orals a little faster.
In the
So
first situation, when you don't want it to give earlier, so when do you initiate in that first set of patients?
I
When
will see if they're responding well just to topicals and orals. Maybe I would not if photo aggravation is a concern. Then those sect of patients, then you are not going to start phototherapy at all.
you
But
start,
90% I would start at the first go itself.
what's your experience with use of hydroxychloroquine in photosensitizing, vitiligo, which is photocognerizing?
I
Have
have no experience with that.
Dr.
I
Devedi?
yes, I have used in quite a few patients because this actinic associated vitiligo is a distinct subset of patients
Yeah.
where we cannot use our, the phototherapy thing in Puasol, and there it really helps along with the regular immunosuppressives and topicals.
So in those
And
patients,
again,
sorry,
sorry.
sorry, go on. I'm sorry, I'm interrupting. Go on,
No, no.
please.
And again, as I said, Dr. Madhulika said, it's like really good to start in the beginning only. We have to be a little less aggressive when the patient is having, unstable vitiligo. A little less aggressive in increasing the doses. Otherwise, it works nice.
Okay, another question. Do we do a regular ANA cell investigation in patients whom we are going to start phototherapy? Do you guys do it? Yes, no?
No.
No, we rely on basic history of the patient. So if that is suggestive of any other symptoms or any other concerns, only then, but not as a regular. No.
Okay,
Yes, but those patients who are having this actinic exacerbated, there I do go for ANA.
okay. Madhulika, how do you ensure that you mentioned adherence? So how do you, okay. So how do you ensure adherence?
I think what goes a long way is the first consultation. It should not be rushed, and a journey or a treatment plan should be laid out in front of the patient, explaining the importance of every step. So for me, I do dedicate and tell them why phototherapy is important, and most patients don't want to be taking oral medicines for a very very long time. So I tell them this is one way of tapering or getting off oral medicines faster if we are really diligent about adhering and complying to the phototherapy instructions. So because once the hair turn white, then there is no chance of repigmentation. We are in a good window. We should capitalize and make the most out of it. So through my talks is how I ensure adherence, basically. Yes.
Thank you. And Dr. Devedi, now you have patients who take home-based phototherapy, right? I mean, I think a lot of people, I feel to the contrary, what you said, I feel like it's something like exercise. Most people will go to a gym more regularly than work out at home. So don't you think people get lax doing therapy at home? And how do you ensure compliance? See, the bigger thing is the compliance, as Madhulika
Yes,
said.
that's the most important thing. So, I have a dedicated staff और जैसे
Oh, yeah.
तुम्हारा स्कूल में अटेंडेंस शीट होता है ना वैसे मेरे यहाँ रखा हुआ है उसका पहले एंड बिगिनिंग ऑफ द मंथ शी हैज अ प्रोग्राम कि आज मुझे इसी पेशेंट को कॉल करना है शी विल जस्ट
Mhm.
टॉक टू देम
Mhm.
एंड वो करना पड़ता है एंड वंस दे स्टार्ट सीइंग द रिजल्ट्स फिर
Mhm.
मोटिवेशन आता है इनिशियल मेरे को फर्स्ट 3 मंथ्स हैंड होल्डिंग करना होता है once they start seeing the result then that is a motivation in itself अब
So
at
I
that point I'm scared कि ओवर ट्रीट ना करे अपने आप को एक बार जब कलर दिखता है तो और ज्यादा कलर ना करे so there I have to take care of that also.
Okay, Dr. Devedi, one more question. I mean, is it possible that, this at some time you want to get the unit back? You don't want to let the patient keep exposing because, somebody
Yes,
at some time might
yes,
blame you that you gave it this chamber and we've been doing it for 20 years now.
that's
So,
what I'm telling you. I told you we have this option of buyback option. At any point, if you are not satisfied with the treatment, we have the option of giving it back to us, and with suitable depreciation, you'll get your money. And I
I
tell you, in
think
the last 15 years, I've got only 15 or 20 units back.
I think Dr. Devedi, you should publish your methodology. I think it's really interesting, and
Amazing
I
question.
would really encourage you to present your work in other forums also. I mean, it was very, very interesting. I really thank both of you for giving such informative talks. They were really good. Yeah, Madhulika.
Make a small comment. So the LIT trial, which compared home phototherapy with clinic-based phototherapy, showed actually better DLQI in the home phototherapy part of the trial, and more adherence to treatment and less missed sessions. So patients, it just shows that patients prefer something that is more accessible and convenient rather than the whole travel situation associated with going to the clinic.
Excellent. Thank you. I think the point has been very well made, where I think take home messages are very, very clear, and home based phototherapy is the thing to go to. Dr. Deepthi is back with us. Yeah, Dr.
Yes.
Deepthi, some last comments can we have? She's moving to
Uh,
another conference. I can see that.
no, I'm just taking. There's another talk,
Okay.
anyways. But I think it was superb. What we've all learned today from Dr. Madhulika and Dr. Dwivedi, and different aspects, some practical aspects of even. I think we are going to all change our practices of home-based phototherapy, as well as what Dr. Madhulika told us. So I'm going to be a changed practitioner.
Thank you. Uh, Dr. Parshuram, we can start closing the session now. I think everybody has to go have dinner also.
So are you taking the slides?
Yes,
Yes,
yes.
I'll just take the slides quickly. So it has been a very fruitful journey. You have to move the slides. Can you move the slide next? Next slide, can I have?
Yes, sir.
Yeah, this next slide. Yeah, this is the slide I want. So the point is this, there is a lot of stigma attached with vitiligo, and patients having vitiligo have to go through a lot. I mean, we have heard about the quality of life, and in so many conferences, we have seen how much psychological burden is there on that. And as dermatologists, we are the best trained to help these people, and we can help each other by sharing knowledge, discussing on forums as such. And I would encourage all of you to become a member of Vitiligo Foundation of India. It's a non-profit organization. We are trying to organize webinars, conferences, and it gives me great pleasure to also tell you that we are going to have our second hands-on cadaveric workshop at Nair Hospital, Mumbai in November. Okay, and this is a real opportunity for you to get to learn how to take a graph, do cell separation on cadavers. We had done it last year. It was a houseful. It was the first time it was done in the whole world, and everybody who attended this cadaveric workshop was willing to come back. So people who are not doing cell transplants, sponge grafting, the surgical workup of vitiligo, I would encourage all of you to join us for this cadaveric workshop. The details you can have on our website, or you can message it on the group. We'll get back to you. I thank all of you for taking out time from after your busy OPDs. And as I said, let's head back home and get some rest. Thank you so much.
Thank you. Thank you.
Okay.
Thank you.
So I would like to take this opportunity on the behalf of Ajanta Pharma. Thank you, Vitiligo Foundation of India, for making this webinar wonderful. With thanks our moderator, Dr. Dipti Ghia and Dr. Munish Paul. So thank you very much. It was a wonderful session moderated by you both. Also, I want to thanks Dr. Madhulika Mhatre and Dr. Ravi Shankar Dwivedi for making sure that how it is important for the treatment, the different aspects of the treatment for the phototherapy. Thank you very much, sir.
Thank you. Okay. Bye.
Thank you all. Thank you. Take care.
Thank you. Good night. Bye-bye.
Good night. Bye.
Take time. You can stop the live.
Okay, sir. Thank
Thank you. Thank you.